Previously, we have discussed about the genetics. Now, let's go back to the drugs. So, why do we study pharmacogenetics? There are impacts of pharmacogenetics concepts, and there are a few advantages when we apply pharmacogenetics in pharmacotherapy. So, the first one, by knowing the genetic information of the patients, then we can determine appropriate dosing, because we know if the person is non-tolerant to a certain drug because of the variation in the metabolizing or receptor that they are carrying, then we can determine the appropriate dosing, whether to increase or decrease. And then next is to avoid unnecessary toxic treatments. So of course, when you already know the genetic information of the patient, and you know that the person has a limited capability of metabolizing a certain drug, then you would want to reduce the amount of drugs given, and that can avoid unnecessary toxicity. And then next is to ensure maximal efficacy. So we can give the optimum dose of the drug so that it can give maximal efficacy without causing overdose or without giving ineffective dosage. And the next, it can also reduce adverse side effects. Then and also when we know the genetic information of the patient, we can also develop or choose novel treatments, because we know that the person or the patient is non-tolerant at all to a certain drug. Then we can suggest an alternative drug. And also it can also explain variable response to illicit drugs. So there are two figures here. The first one is on the left. So in a population, you have a group of person or people that metabolize a drug fast, and then some of them metabolize normally, and then some of them metabolize slowly. So this is what we call polymorphism. And then another example here, we have a group of patients with the same diagnosis and same prescription of drug, same dose, but you have different responses. Okay, so the first group, the green group, they say that the drug is toxic but is beneficial, and then the red group says that the drug is toxic and also not beneficial. So this is the least fortunate group, because they gain nothing. They only get toxicity, but they didn't get any beneficial effects from the drug. And the yellow group says that the drug is not toxic but also not beneficial, so nothing to lose, nothing to gain. And then the last one, the white group, is the most fortunate one, because the drug is not toxic and also beneficial to the disease. Okay, now let's go to the story of warfarin. So warfarin is the most widely used anticoagulant in the world. It is also known as a blood thinner. And it is prescribed. The prescribed doses vary widely from 1 to 40 milligram daily, and therapeutic index is very low. So remember again, therapeutic index is the function of LD50 divided by ED50. So if the LD50 is high, then the therapeutic index is very low, and vice versa. So in this case, when the therapeutic index is low, then LD50 is also low, which means it has a narrow therapeutic window. And that's why there's a high risk of bleeding early in the treatment. Okay, because you tend to give a higher dose to the person that can give the side effects of bleeding. There are two genes involved in metabolism of warfarin. The first one is CYP2C9, and so CYP2C9 is the cytochrome P450, and species 2C9. So this is the metabolizing enzyme that metabolizes warfarin in the liver into inactive one. And then the second one is VKORC1 is vitamin K epoxide reductase complex subunit 1. So VKORC1 is the drug target. Okay, this is what this is the enzyme that warfarin targets. So in normal condition, this VKORC1 actually reduces vitamin K, vitamin K2,3 epoxide, and then VKORC1 catalyzes this reaction or reduces into vitamin K, and this vitamin K will further be used for the activation of clotting factor. So the function of warfarin is to inhibit this VKORC1, and thereby the VK or vitamin K2,3 epoxide will not be reduced, and there is no available vitamin K to be used to activate the clotting factors, and that's why it becomes the blood thinner. So warfarin is metabolized by CYP2C9 into metabolites. So this is under pharmacokinetics, and then warfarin targets VKORC1. So it inhibits the VKORC1, and this is under pharmacodynamics. So this diagram shows you the differences in therapeutic windows in 3 different variants. The first one is homozygous wild type. This is normal one. Homozygous wild type CYP2C9 and VKORC1. And the second one is the carrier of CYP2C9 mutant allele. And then the last one is carrier of VKORC1 mutant allele. So for homozygous wild type, in the therapeutic window, the patient's INR is within specified limit. INR is international normalized ratio. So this INR represents the clotting time. Okay, it represents the clotting time. If the INR is low, that means the blood easily gets coagulated. And then if INR is high, then it means that the blood takes longer time to coagulate. So by giving the dose within the therapeutic window, the patient is anticoagulated. Warfarin treatment is safe and effective. But in the case of patients, INR is lower. So when INR is lower, then that means the blood can clot or coagulate easily. So if you give low dose of warfarin, then the patient gains little or no therapeutic benefit. Okay, because it's not effective at all. And then this is the vice versa of this one. All right. But in the case of the patient that carries CYP2C9 mutant allele, the therapeutic window is shifted to the left, because when there is a mutation or variation in this cytochrome, then it will have a reduced capability of metabolizing warfarin. So when it has a reduced ability, that means if you give too much warfarin, then it will cause overdose. And that's why you have to lower down warfarin so that it will not cause overdose. And then for carrier of VKORC1, because if you have a mutation or variation in this enzyme, that means that it has reduced affinity to the warfarin. Okay, it has reduced affinity to warfarin. That means it does not bind effectively. The warfarin does not bind effectively on VKORC1, and that's why you need more warfarin to saturate the enzymes. Alright, so this is a journal article they have reported the estimation of warfarin dose based on the clinical and pharmacogenetic data. So if you see this table first, if you see this table, star 1 is the normal allele of CYP2C9. So if both of the alleles are normal, then the person will be an extensive metabolizers, normal. But if the alleles is star 1, which is the normal one, and then star 2 is the variation, then he will become intermediate metabolizers. But if the person has star 1, star 3, or star 2, star 2, or star 3, star 3, he will become intermediate or poor metabolizers. And on the right side of the table shows the days taken by these individual CYP2C9 genotypes to stabilize the dose of warfarin. And then in the bar chart, actually it gives the same information, but in addition to the variation in the VKORC1. So GG is the normal one. It's the normal phenotype of VKORC1, and then GA is heterozygous, with G is the dominant, the normal one, and then A is the recessive, and then you have AA, which is a mutant. So so the first chart, the first bar shows the person has a normal CYP2C9 and normal VKORC1. So he can tolerate up to 5 milligram of warfarin per day. And then if he has a mutation in the VKORC1 but not in the CYP2C9, then he can tolerate up to 4 milligram, and so on and so forth. Okay, now this is another story of anti-clotting drug, which is called Plavix, and Plavix is the brand name. The drug's name is clopidogrel. So it is an anti-clotting drug prescribed for coronary artery disease and those who have suffered a heart attack or stroke or have a stent. It is a prodrug converted to active form in the liver by CYP2C19. Okay, so remember, prodrug, it has to be metabolized, then it will become active drug. So the metabolization is carried out by CYP2C19. And this group of researchers have found that the cytochrome P450 polymorphisms and response to clopidogrel, so they actually found that the polymorphisms in one of the cytochrome P450 actually affects the response to clopidogrel. So they have carried out a research or study using several types of CYP here, and then from their study they found out in terms of pharmacokinetic response, polymorphism in CYP2C19 is highly affected the pharmacokinetic response of clopidogrel. So this was measured by measuring the concentration of active clopidogrel in the blood after administration of the prodrug. So you can see here that the amount or the concentration of drug is very much affected compared to other polymorphisms in other cytochrome P450. And then for pharmacodynamic response, this was measured by measuring the aggregation of platelet, and you can also see that the polymorphism in CYP2C19 highly affected the platelet aggregation. Okay. So from these two figures, uh, they concluded that CYP2C19 mutant carriers had reduced presence of the active ingredient, which is pharmacokinetics, and reduced thinning, the pharmacodynamics.